Hello, my name is Tristan Herring with the Personality Assessment and Treatment Seeking Lab at Texas Tech University's Department of Psychological Sciences. I'm presenting a poster titled Contrasting Efficacy of Clinician Judgment and Self-Report of Suicide Risk in a Sample of Veterans Receiving Outpatient Treatment. Veteran suicidality constitutes a major health epidemic, with over 89,000 veterans committing suicide between 2005 and 2018. In fact, suicide recently surpassed combat-related deaths in post 9/11 veterans. This shows how pivotal it is that we find the best treatment possible for those veterans at risk. The first step of the treatment, however, is accurate assessment. Not only do we need to accurately assess whether or not a veteran is at risk of suicide, but we need to know the severity at which they present. Enter our study. We examined the accuracy of clinician judgment of licensed therapists who work regularly with veterans by comparing their judgment of risk to the Validated Suicide Behaviors Questionnaire Revised, aka SBQR, levels of risk. The assessments were performed at clinical intake of an outpatient non-VA mental health treatment program for veterans and first responders. However, our participants were restricted to only veterans. For more information on our participants, we had 246 veterans that were predominantly male with an average age of 38.8 years old. They were predominantly honorably discharged, with about half coming from the Army, about a quarter from the Marines, about 17% coming from the Navy, about 17% coming from the Air Force, and about 2% coming from other departments. About half were deployed in combat, and they averaged a total of 7.7 years served. And during the clinical interview, licensed clinicians rated perceptions of client suicidality as mild, moderate, or severe, based on their own judgment. Suicidality was also assessed via the Suicide Behaviors Questionnaire, again called the SBQR. Clinician judgment was compared across contrasting levels of validated risk as identified on the SBQR. Higher sensitivity, indicating better detection of potential suicidality, was prioritized during interpretation. In our study, we ran an ANOVA analysis, correlational analyses, a receiver-operator curve, and moderation analyses. What we found was that low to medium sensitivity at the recommended SBQR cut scores suggest that clinicians may mismatch some with level of risk compared to the SBQR screening measure. When identified risk is high by clinician judgment, it is likely highly evident, aka high specificity. Most pronounced cases of suicide remain those with which we can trust clinician judgment. Furthermore, levels of clinician-identified risk demonstrated large effect size differences, and greater differences in severity of risk had larger effect sizes. These findings suggest that judgment of severity is more accurate at assessing large differences in degrees of severity, aka none versus severe, but less accurate when discriminating between close ratings, for example, none versus mild. Our moderation analyses did not find a significant impact of combat deployment or discharge status on the ability of a clinician to accurately assess levels of risk. So what does all of this mean? Our take-home messages are that clinician judgment of risk is significantly associated with the validated SBQR levels of risk. This relationship suggests that licensed therapist judgment of suicidality is a selectively valid form of assessment. The association contrasts some historical concerns over clinician judgment of suicide risk. The accuracy and ease of clinician judgment suggests an imperfect but valuable utility in veteran suicide risk assessment. Clinical judgment performed by licensed therapists who work with veterans offers a critical risk assessment method. This study, like all others, is not without its limitations. Use of the SBQR is somewhat limited as an outcome variable given its abbreviated form, while such measures are frequent in measurement-based care systems, they themselves are not wholly predictive of suicide risk because of how suicidality can develop. Furthermore, replication and extension of these findings to other measures of risk and to other high-impact decisions are necessary to further determine the comparative utility of brief measures of clinical constructs and simplified levels of clinician judgment. Thank you guys for listening to my presentation. I hope you have a wonderful time at the conference.